Good morning. Today is Monday, December the 7th, and we are going to continue with chapter 9 and the traumatic brain injury. I'm going to turn off my camera light because I think that it looks a little bit better and you don't get that glare of the light, the intensity of the light in my glasses, which kind of looks spooky, I think. So, hope you had a good weekend. You're home now. Uh, Remember that the final will be over chapters 8 and 9, and any additional information that I share with you. I think with traumatic brain injury, I would encourage you to get some paper, take some notes, because some of the information that I'm going to share with you will not be in the PowerPoint. It is to supplement the PowerPoint information. So it would be a good idea, excuse me, for you to take some notes. Okay? Very good. Well, traumatic brain injury, or otherwise known as TBI, traumatic brain injury, TBI. And traumatic brain injury is what accounts for about 75% concussions. Now, and about half of that, 75%, is due to car accidents. So the concussion accounts for 75%, and vehicular accidents account for 50% of that 75, which means that the accident can be caused by a fall, a gunshot. Sports injuries are big. If you're watching football, you see it quite a bit. The injuries, an athlete doesn't get up, he seems groggy. Some of the medical personnel come out onto the field, they take him to the side, and they take him in a tent, and they do this quick assessment. If he doesn't pass that assessment, then they will take him probably to the locker room and do a little bit more. In terms of sports injuries, we know a lot more now, especially with football and numerous concussions. We also see numerous concussions in race car drivers. Dale Earnhardt Jr. is a prime example. If you've read anything about him, you will learn that he has had numerous concussions. And the last concussion that he had prior to his retirement went on for quite a while. Double vision, unsteady gait, memory, thought process, receptive language, expressive language. So car accidents, I think it's a given with racing. Also, there's childhood abuse and spousal abuse. Shaken baby syndrome will result in a TBI. The shaken baby situations that I've been in, that I have been involved in as the speech pathologist, these kiddos were severely impaired, severely impaired. They went from language to no language, walking to not walking, to be pretty much quadriplegics. They are significantly impaired in language, and language development has halted for sure, for sure. So we do see bicycle accidents, these hoverboards, the skateboards. I see skateboards all over campus. Also, boating accidents or accidents on the wave runners. There was a young man that was in the clinic for therapy, and he was on a wave runner or a skidoo, whatever you call them, and he hit another one. He was knocked unconscious and he went through rehabilitation, and he came into the clinic for therapy because he was an LEd major, and he was a physical education teacher is what his degree was going to be when he graduated. And we went through some very functional activities in which he would explain to the students what they were supposed to do. He worked on lectures so that he could deliver a very fluent lecture. Memory became an issue, so we worked on some memory issues. So boating accidents or with the wave runners. A lot of leisure activities, falls, if you're out hiking, sometimes the footing is very slippery and you may fall quite a distance. Well, what you're going to hit is your head, more than likely if there is something to break your fall. So traumatic brain injuries, we know 75% are concussions, and they're caused by, uh, half of that 75 is caused by car accidents. Now, with children and adults, you're going to see the most common reason to be falls, especially with an individual who's over the age of 75. And I would have to say even before that. And if you have someone who is diagnosed with Parkinson's disease and it impacts their gait, how they walk, that could be a fall issue even prior to 75. So there are circumstances under which someone would be more of a fall risk. If somebody had a stroke, and which is a cerebral vascular accident, and we will talk about that. But if there was a fall for some other reason, it could be before 75. And the little ones not being carefully supervised, kids are curious, they climb up the ladder of the slide, they walk to the very top step and bam, one foot goes down and they tumble. So falls are a big reason. Some individuals will fully recover. It depends on the age of onset. It depends on intervention, how quickly they get intervention, how thorough the intervention is, the part of the brain that has been involved in that traumatic brain injury. So that there are several factors that play into recovery. Sometimes recovery can take weeks, months, and even years later if you're tired, if you're not feeling well. Some of those symptoms creep back in to your language, into your ability to function normally on a daily basis. Cognition many times is involved, sensory processing, the senses, vision, smell, touch, taste, even the information that you receive through your extremities, that touch the joints. Some of those areas are also involved. Communication for sure, academic learning, oh my gosh, and mental health issues. Now, when we talk about sensory processing, I want to remind you of the cranial nerves. You have 12 pairs, if you remember correctly. You have 12 on each side, so you have a total of 24. And those cranial nerves are up in the head area, innervating your ability to lift your eyebrows, to open and close your eyes, to grin, to hear, to see, to smell, to taste, to have symmetry in your face, where you have both sides that work together as opposed to one side that maybe droops due to a cranial nerve damage on one side. You may have family members who've had strokes. Again, that's the CVA, and they have hemiparesis. They have unilateral drooping. The muscle tone isn't good. In children, as well as adults, but with children, we especially see this in school, the distractibility. They just simply can't concentrate. They may perseverate. And if you don't know what perseveration is, it's neurologically based, and it means that they're doing the same thing, saying the same thing over and over again. One way that I describe that, there was a child that was in the clinic, and the child was in the playroom, which is a waiting room, but it has toys and it had a small kitchen, small child-sized kitchen. And the child went in, and the child opened the door, closed the door, opened the door, closed the door, opened the door, closed the door. It was a little cabinet door. Well, the child there was no purpose in that activity. The child didn't pause and look inside for anything. The child didn't stop and then go to the next door. The child was stuck at one door and was opening and closing that door without purpose. That's perseveration. So what you might want to try doing if you have a child that you're working with that does that, you want to break that pattern in some way. Not break it, but you want to interrupt it is a better word. You may go over, talk to the child, put something in the cabinet on the shelf, and then direct the child's attention to that object, something like that. But perseveration. And they become frustrated very, very easy. There's agitation, just this underlying level of agitation or anger, and they become frustrated very, very easily. Excuse me. Early in the morning, it's 7:38 according to my clock. Children may not be topic focused. They can't organize their thoughts, frontal lobe information. They have difficulty expressing complex ideas orally or in writing. They know, okay, now what was I supposed to write? They have the pen, they have the paper, but they're just not able to generate, okay, now how do I write that? How do I formulate that sentence? Automatic language doesn't seem to be affected. Now, an example of automatic language is counting from 1 to 10, saying the days of the week, the months of the year, that automatic information, giving your address, giving your phone number. That's information that's in that long-term memory, and automatic information doesn't seem to be too difficult. New information would be very difficult. Let's say, for example, they moved and they had a new address. They may continue to give that old address. Language comprehension is difficult. Body language, nonverbal signals, and emotions may not be accurately interpreted. They may cry easily, become upset, may not be able to explain to you why. Now, with some brain injuries, there is a scale called the Glasgow Coma Scale. And I'm going to put it up here so that you can see it. Glasgow Coma Scale. Now, some ambulance services, emergency teams, when they go out to an accident, they may use this Glasgow Coma Scale to assess the individual that they come upon right away. They're looking at the response to the eye-opening, verbal response, and a motor response. And then what they're going to do is they're going to assign it a number. Much like APGAR scores, when we talked about the girl in the window and she had a 9, and we're assigning a number rating. And that number rating tells us if the individual has a severe head injury, moderate, mild, etc. And then the EMTs would then collect that information after they did vitals and got the individual into the ambulance. They would call ahead to the emergency room and give them that information. So they're using a Glasgow Coma Scale. Now, it's to help gauge the impact of the condition of the brain and how much damage may be caused. Now, you don't know at that point because there are a lot of other factors that play into that. You can have internal injuries. If you have somebody who's on a blood thinner, they could be bleeding internally. There could be damage to the kidneys. You could have a tear in the spleen, just lots of other things. But they're going to use some kind of a scale. Now, I would encourage you to write down Glasgow Coma Scale because there probably will be a question on the final about the Glasgow Coma Scale. It won't be anything detailed. It'll be something that's in more of a general format. Okay. All right. We as educators know that children can have a TBI. They can go through the windshield. Now we have seat belts today, which we didn't have seat belts when I was a kiddo. We never wore seat belts. The young toddler may have been sitting on the mom's lap in the front seat. We had an old 57 Chevy, and it was really cool. It was turquoise and white, and it was a big tank kind of car, and it was a standard shift. It wasn't an automatic, and I don't even think that car had seatbelts in it. And it's not that they were taken out, but that just wasn't a big issue. And there probably was more damage at that point than maybe what we have today, although our speeds are probably contributing to more. But you may have a child in your classroom who has had a TBI. And I'm going to just give you a little information as to what you might see on a more specific level in kiddos who have experienced a traumatic brain injury. This came from school reintegration within the pediatric traumatic brain injury population by Elizabeth Begin. She's a PhD, and her manifestations of TBI by age. And we're looking at a preschooler, and you're going to see similarities in several age groups. Irritability and crying. The sensory system just is full of static, and things just don't make sense, and everything is disorganized, and so there's irritability and crying. Temper tantrums. Frustration, fearful. They're fearful. Disabilities become evident over time as higher level skills are expected to develop. So when we get into higher level language skills, when the expectation for language in complex sentences, abstract concepts become part of the curriculum, these kids their disabilities become more evident. Preschoolers, elementary school, difficulty learning new information. Now let's say that you were a kiddo who already had difficulty learning new information, and you were in a car accident, a fall, whatever the cause was. and now you have a traumatic brain injury. And that just exacerbates the problem that you already had with learning new information. Short attention span, impulsive. Doesn't that sound like ADHD? Short attention span and impulsivity. Let's say, for example, that you already had that condition and now we've made it worse. Frustration, inappropriate social interactions. Now, that could be the child who's running up and hitting and maybe using inappropriate language and tripping kids and mean. Um, and this is a child who wasn't like that before. So you have a change. You have a change in their behavior and their personality. Again, the disabilities become more evident as the language load increases. Middle school and high school. Difficulty with new learning again. Now remember, we're reading to learn, and the material is more difficult. Short attention span, impulsivity, we saw that in the elementary school child. Executive deficits noticed. Now this is where the child has to keep track of when an assignment is due. When is the test due? What chapters is the test over? What was I supposed to read in history? How many problems was I supposed to complete in math? What pages were those math questions on, or math problems? Decreased social judgment, frustration over things that you could do at one time and you can no longer do. So we've got some depression and anxiety entering into this. Their executive function, which helps keep us, I say, on the straight and narrow, that kind of is a barometer about, better not do that because I could get hurt doing that. It's not a safe decision. They are taking risks that they didn't take before. Sexuality concerns, they may become more promiscuous. And effects of the earlier injury become more evident. So we see things that maybe we didn't see early on. As a result of some of these changes, friends may go by the wayside. They're not calling to ask you if you want to go to a movie, come over and hang out. They're not because your friends want to be mean, it's because the friends don't know what to do. So educating them a little bit, talking about a traumatic brain injury, even maybe having the students' parents come in and talk about their child and what happened and what they can do to help may be very beneficial. Families are in mourning. They're making decisions. They're thinking with their heart, with their emotions, maybe more so than they're with their heads early on. But what happened to my straight A college-bound student? What happened? Because they can't do calculus anymore. They can't do algebra. Maybe they can't even add. And so parents are mourning. Teachers are frustrated. How many of you who are education majors have had any, or well, maybe any, or much instruction on how to deal with, in terms of academics and teaching, with a child that's had a brain injury? Probably not a whole lot. And so you have to rely on experts, the doctors. You're going to have to maybe do some of your own research. So the student is at risk for isolation, academic failure, depression, substance abuse. I just want this pain to go away. Delinquency, and possibly due to taking risks, another TBI. I had a student in one of my classes. she was kind enough to share her TBI, and it was due. If I remember correctly, it was during a car accident. She had to learn the alphabet again. She couldn't do math. She was in high school, and then she had another TBI a few years later as a result of a sports accident. Wow. Took her a long time to be able to recover from that to where she could function in the classroom. So, my point behind this TBI information is you may have a child in your classroom. Speech pathologists will certainly have individuals with TBIs. And it's not just the 50, 60, 70-year-old. Children have TBIs as well. Now, some other things that you can do to help this student along the way, because they want to get back to school. They want to be with their friends. They feel like they can handle a whole day of academic work, and they sometimes have to just try it. We can tell them, let's just have you go one period a day and maybe eat lunch with your friends and then come home and then add, because it's very, very fatiguing. Remember when I talked about if you have a hearing loss and that listening, you have a vision loss, that the use of your eyes and the concentration that takes place, excuse me, it's fatiguing. You tire, you get frustrated because you can't keep up. And we can tell these kids, okay, it's really not a good thing. Let's start with an easier class. Let's start with maybe a speech class, and you're just going to go in and listen to your friends give a speech. And that's it. And then you're going to have lunch and you're going to come home. They don't want to do that. They want the life that they had. And they mourn as well as their parents do. So, children injured at a younger age may not demonstrate some of the full effects until they're required to demonstrate these advanced language skills. And there's more expectation on them. The child may need an IEP or a 504. You, as the classroom teacher, may have to initiate that. You want to think about functional goals. And I think anytime that we're talking about speech therapy or even some things in the classroom, what's functional? What's going to make sense? What's going to help the student reintegrate, get him back into school? Let's get this entry going. But may go back part-time. They may have altered assignments. Let's say that you give your math students questions 1 through 20, or math problems 1 through 20. Maybe you're going to give the child who's re-entering school every other problem to do. They need extra breaks. You've got to think about your teaching style. They may need somebody to come in and take notes for them, and that's okay. But you know what? It's going to make them feel different, and they don't want to be different. You may ask the parent to come in before the student comes back to class and talk about the students. Maybe the student's in a wheelchair. Let the students ask questions about that wheelchair. Maybe they want to ride in the wheelchair. Now, it's going to depend on how cooperative the student in the wheelchair is, but take the fear out of it for these kiddos. They may need to have a reassessment. Maybe you could do some Zoom prior to them coming back. They may have medication that makes them sleepy, gives them headaches, takes the hunger away. They maybe have lost a lot of weight. They maybe look very different. Maybe they had to have their hair cut. So the children are curious I don't think they want to be mean, but they definitely are curious. You may have some unpredictable behavior from the child who's coming back to school, and that will have to be addressed as well. Okay, all right. Now, be patient with them, and I know you're, as a teacher, may feel like I've got enough to do without adding extra work. I have two bilingual children in my classroom, and now I have a child who is re-entering my classroom after a traumatic brain injury, and it's challenging. You just have to be persistent, I think, with going to your administrators and asking for help. And the parents can be very helpful in that regard too. They don't typically, I do want to add this, they don't typically have phonological problems, articulation problems. If they didn't have them before, they probably will not have them after the TBI. But they could have some motor speech problems. They may hesitate when they speak. They have to think about what they want to say. The, the speech may be slower. So there could be some differences there too. So that's traumatic brain injury. Many times when students in the past have gone for spring break and they go to Florida or someplace, the mommy in me comes out and I say, don't walk down a dark alley, don't go any place with a stranger, and don't do anything that's going to give you a TBI potentially. So we don't want any more TBIs. All right, let's now talk about a stroke. A stroke, and you may have had somebody in your family that's had a stroke. That's also a CVA, cerebrovascular accident. Now most of this that I'm going to talk about will be in the PowerPoint. The information on TBI and reentry into school and the things you have to think about, that is not necessarily in the PowerPoint. So hopefully you took some notes or you can go back and review. It's another cause of a brain injury, and it's triggered by the lack of blood flow and oxygen to the brain. Now, you've probably heard, well, the brain's only going to be able to survive so long without oxygen, and that's true. You've got anoxia and you've got hypoxia, and I think we've already talked about that. I'm looking through here real quickly to see if that's something that, yes. Remember, hypoxia is a lack of oxygen, and anoxia is the absence, absence of. So you have, due to some cerebral vascular accident, a blood clot, which impacts the blood to be able to flow and carry oxygen to the brain, or an aneurysm, which has just kind of blown out and also causes an interruption of the flow of blood. And you have many different levels of CVAs. It can be mild. Oh, sometimes you'll hear someone say, oh, he just had a little TIA. Well, that's like a little mini stroke, and it was just something that was very small, minor, mild. And it maybe goes undetected at the time. But I'll tell you, that could be an indicator you're going to have another TIA at some point. You're more likely to, or you may have a major stroke. Something is happening within your vascular system and the flow of blood. Strokes can also occur prenatally in the womb or any time in somebody's life. Babies, infants can have a cerebrovascular accident or a CVA during the birthing process, shortly after, and those APGAR scores will reflect something that isn't quite typical, isn't quite what we want to see of a newborn. Twins are at risk. Any multiple birth is a at-risk pregnancy. And as you can well imagine, there's only so much room for two babies. And usually those babies will be taken via C-section, which makes it safer for that baby. But that doesn't mean that there still can't be a problem, and it may result in a CVA. CVA is the leading cause of death in the U.S., and 10% of children who have a stroke will die. There are long-term disabilities as a result of that. And I will tell you that the prognosis improves if the person is discovered quickly, emergency team gets to them quickly, they get to the hospital quickly, and intervention is provided quickly. Also, the therapies that the person gets, it could be speech therapy, occupational therapy, physical therapy. You live on a farm and you're 25 miles from the hospital. It may be a hardship for you to get to the hospital, to the rehab department, to continue your therapies, which will help you. So how aggressive the intervention is, your support system is also very vital in terms of your recovery. Now, let's say you live alone. You're a 75-year-old woman and your son lives 2 states away. And so you're pretty much taking care of yourself. Neighbors look in on you from time to time, but you yourself may miss some of the signs that will crop up that are not normal, and you will miss them. And then your son is 2 states away and he can't get to you quickly. It exacerbates the problem where an individual could lay on the floor for 2 days before someone finds them. I know an individual who is probably about the same age as me. I'm 66, and he's probably really close to that. And I saw him in the clinic, and I had no idea, and hadn't seen him for quite some time. And he had a brain bleed and laid on the floor, I don't know how many hours. As a result, nonverbal. He he was partially paralyzed on one side. We were just never able, depressed, and we were never able to get him to a level where he could use some kind of voice synthesized device. He became very frustrated, wouldn't get out of bed to come to therapy. But he was without medical attention for a long time. Now, what would have been the end result if he had had medical attention and somebody was with him? He lived alone. I don't know. You can't play that what if game. You can't go there because it'll just drive you crazy. It'll make your life as the caregiver even worse. So, but he went a long time without help. And he was supposed to be on the farm helping, and he didn't show up, and then somebody went and checked on him, and they found him. So he was alive, but he had a pretty significant brain bleed. There are risk factors for heart disease, some other vascular anomalies. Children are more likely to recover than adults due to that neuroplasticity of the brain. And we've talked about that plasticity, that cognitive plasticity. The brain is still developing, and children do have a tendency to do better in recovery, for sure. Children do better in recovery for lots of things, more so than adults. So, and typically there is somebody with them, and they have somebody watching over them, taking care of them, and they're not left alone, and so they can get medical attention much sooner. Okay, that is CVA. cerebral vascular accident, and TBIs. Now we're going to talk about learning disability a little bit. Now, a learning disability, of course, we know that those individuals with that diagnosis have a normal IQ. It's difficulty acquiring spoken language, written language, and math skills. And those are probably the three big areas that children go to the resource room for. When I was working in public school as the SLP, the resource room teacher and I shared a classroom, and it was divided by a partition, and we could hear everything that was being said. So it wasn't ideal, but it was better than the girls' locker room that I was in when I started in the public school. So I took that over the girls' locker room. But and I also feel like historically, when LD came onto the scene, that it was sort of a dumping ground. These kids aren't successful. There's something wrong with their overall language processing, their ability to learn, retain, whatever you want to call it. And so a lot of times kids were placed with the resource teacher when in reality we were missing the whole thing. We were missing the boat, so to speak. So we know that it's spoken language, acquiring spoken language, written language, and math skills. It's not a sensory issue. It's not an intellectual problem. It's not an emotional disorder. And it's not due to any environmental factors. It has to do with brain function. And for some reason, those kiddos learn differently. The style of learning is different. And this is where I think our kids who years ago really had or should have been diagnosed with dyslexia, they were placed into the LD resource room, and that teacher didn't really know how to deal with the dyslexia. But that's where they were placed. And that's why I say when I started teaching in the public school, the SLP was in the 70s. It was before IEPs. That's how old I am. But IEPs came into being a couple of years after I started in the public school. And then the language LD teacher came into play. And kids, they didn't know where to put them. I can remember the LD resource teacher had a really sweet boy with a diagnosis of Down syndrome. She had a child probably with a diagnosis of autism. If they didn't know where to put these kiddos, that's where they went, to the resource room. I don't think it's so much like that today. We presume it to be due to some sort of central nervous system dysfunction. There's an interruption. They're just wired differently. That's how I describe it many times. The wiring is just different. We don't know why, but it is. But it is a lifelong problem. But the really cool thing about it is these kiddos learn to compensate. And we see that learning disabilities run in families. Just like stuttering runs in families, autism may run in families. These kiddos that are in the LD, learning disabled range, it runs in families. So parents know how they felt. Parents know what worked for them. And we see these kids compensating. And when they get older, they've learned how to get around that deficit to help themselves learn. The incidence varies. I think the statistics in the book are probably outdated. In the book is the most recent edition. But I think now that we have recognized dyslexia, I think that the statistics are going to change even more. In the school-age population, according to the text, which is ages 6 through 21, There are close to 3 million children receiving special education. And again, it's like communication disorders. There are so many different communication disorders, so many different facets to learning disabilities that it depends on the statistic that you read. Now, there is a specific learning disability that has a neurological origin, SLD, SLD, specific learning disability. And these children usually have difficulty with phonological components to decode words. Sounds like dyslexia to me a little bit. Difficulty in word recognition and reading comprehension is poor. Again, we see similarities with dyslexia, and they're very poor spellers. Again, we see similarities to dyslexia. It is not a hearing loss or accompanied by a hearing loss or intelligence or a vision loss or motor function. It's a neurological issue. Language acquisition is typically developing, but there may be delays that are just uneven. So, for example, vocabulary may be delayed by 2 years, but the grammar may show a 3-year delay. Well, you would expect those delays to run parallel, and they don't. So we've got some uneven development in a specific language impairment. Deficits in short-term memory and working memory. You've got to be able to hold on to information in order to add new information or to solve a problem or to remember that information as you build your education in areas. They have mild pragmatic deficits. Now remember, pragmatics is social communication. They will maybe have mild pragmatic deficits. It's usually identified as a learning disability. And the higher level language skills in the classroom will cause them problems. Language and cognition. Language and cognition. Okay. I'm going to stop there. I've lectured for almost 50 minutes. We are going to get into a little bit about some speech disorders. And I think, but I'm not going to cover a whole lot. Some of this we have already talked about, but certainly I think the next lecture will gloss over some of the speech disorders that you'll see in the classroom along with phonological disorders. And then I want to get into dyslexia just a little bit more. I want you to have some information there, and that will probably finish us up. So I may finish up with the lecture on Wednesday. Then that would take me into Friday potentially for the review. The 11th could potentially be the review. Or if we don't get it on the 11th, it will be on Monday the 14th. I'm thinking that the test will open on the 15th and close on the 17th. I will post, I'll have it written out and I'll show it to you, and then I'll put it on Canvas as well. Okay? Well, have a good day. It's still kind of dark outside. If you have questions, let me know, and I will talk to you soon. Bye.